Okay, so I know we're kind of trucking along here. We've got, we did the elbow on the weekend. Now we're doing the wrist. But your test is on the GH and scapula, right? So we're always learning something new, and then you review the other stuff, do your test, right? Learn something new. So I know it can be a bit overwhelming. So that's why just stop me anytime if you have questions. Try to absorb as much as you can, and then you know that this PowerPoint is recorded, so you can always watch it again later on. So we're doing our same old outline, and now we're looking at the wrist. So hopefully you can see in these images the different motions of the wrist. So if we're talking about anatomical position, and we bring the palms of our hands closer to our body, what is that an example of? Circle. Here, I'm going to let you guys draw. Oh, almost everybody got a marker. That's awesome. You can circle the one that we're talking about. So if you're in anatomical, you bring your palms closer to your body. Yes, we are talking about wrist flexion. So then the opposite of that would be wrist. Yes, wrist extension. Very good. Okay, so now again, anatomical, and we bring our pinky fingers closer to our body or to our sides of our body or away. So towards is which one? From anatomical now. Oh, careful. There's no erase button, eh? I know. So it's ulnar deviation, which in some books is, they call it adduction. And then radial deviation is also called abduction. So it's a little tricky because the images I put on the screen, the person's not in anatomical position. We're not looking at an anatomical position, right? So you have to kind of think about how is this hand going and what's it doing? And remember, that's what I warned you about with the elbow and forearm, is that it can get really confusing because we have so much range of motion and we move our arm around and we don't realize which side we're on. So as a rule of thumb, just remember, go back to anatomical and then try figure it out. Figure out the origin, insertion, action. So start from anatomical. So the good news is we already talked about quite a few of these bones, right? The ulna and the radius, and we're going to get into the hand. But we're going to do a little review of the elbow. We did that on Sunday. So we can take another little look here. We've got the trochlear notch, which is here. The trochlear notch is part of the ulna, and it is directly in front of the olecranon process. Then we got the coronoid, which is W here, the bump. And we now know brachialis inserts there. And what was the deal with the radial notch? What was the trick we talked about in class to try remember? Because remember, these are bony landmarks of the ulna. So why is it called radial notch? Good, like a bowl of soup. It's holding the radius, the head of the radius. Good. So you can hardly see it there, the radial notch. Why? 1 is pointing to it. And then we have an ulnar tuberosity, which is a bigger bump. Oh, question? Oh no, someone just logged in. That's good. The ulnar tuberosity and the brachialis also inserts there. So brachialis is a pretty large insertion. And then, as we learned, the head of the ulna is actually the distal end. And the styloid process of the ulna is the part that looks like a pen or a pencil or something. Okay, so now you've had a bit of a moment to, you mean you've had like a day or two to let this stuff gel in your brain a little bit. And the difference between these two images here that we're looking at is the image on the left, so this first image here, number 1, is a disarticulated view. Okay, that's how come we can see the trochlear notch. We can see why. We can see this part here. But normally, hopefully, your elbow is not dislocated and we cannot see the trochlear notch because it is hidden. The trochlea, which is this part here, or L of the humerus, fits into it, like in image number 2. Does anyone remember what this round part of the humerus was that articulates with the head of the radius? Oh, yeah, very close, Liz. Capitulum, because you wear a cap on the head. Very good. See? Something sticks from Sunday. That's good. And now we got the radius. So the head of the radius is proximal, and then it's got a neck. It has a tuberosity as well, a shaft. Of course, they both have shafts. They're long bones, so they have shafts. And then at the bottom, we have the styloid process and also the ulnar notch, which you can't see here, but I'm going to shade it in. So the ulnar notch is on the radius. So again, this is that whole soup bowl business. The ulnar notch is on the radius holding the head of the ulna. So both notches hold the head of the other bone, if that makes sense. Crystal pointed that out, I think, in class. So that's a good analogy. All right. Okay, now we're going to move beyond now the arms of the forearm, and we're moving into the hand. And this is going to remind you, hopefully, of the foot. Okay, so remember, let's relate it to something we already know. We already did the leg, right? So let's take the upper extremity and relate it to the lower extremity. So remember in the foot, we had bones of the ankle, and they were called tarsals. Well, in the wrist and hand, we've got carpals. Okay, so we've all heard carpal tunnel, right? That just means your wrist. Carpal means wrist. So there are 8 carpal bones situated pretty much in 2 rows-ish, okay? So if we look, we have A, B, C, and D in one row, and then in front of them, E, F, G, H, like in the image, okay? So they all got funny names, and yes, you have to know these names. So what we usually do is we start in the proximal row on the lateral or radial side. So remember the 2 bones down here, this one here is your radius and this one is the ulna. Okay, so we're going to start proximal closer to the radius. We're going to start with A. So that's your scaphoid. And next comes your lunate, then your triquetrum, and then sitting on top of the triquetrum is your pisiform. Now this one you can feel. If you, we might need the webcam. Let's see. Can you guys see me? Ah, there I am. All right. So if you look at your wrist, and you see, you have your wrist, the crease in your wrist. If you go just above it, closer to your pinky, you're going to feel something really, really round. That is your pisiform. It's very round. Okay, can you guys all find it? It's important to know this because this is where your carpal bones are. Lots of people think they're up in here. That is not true. They're down here. Okay, so you find your pisiform, that's a good landmark. Okay, webcam off. All right. Then we're going to go back across towards the thumb, and we've got the trapezium, trapezoid, capitate, and hamate. So if you found your pisiform, go a little bit more distal, so away from it, more into your hand, and a tiny bit lateral. You should feel like another bump. That is called the hook of your hamate. Okay, so you're starting on your pisiform and you're going to end up here on this bump. That's the hook of the hamate. It's quite a prominent bump in the carpals as well. Okay, so now we need a way to remember this, right? So there's a few things. The problem is we have a few words that start with the letter T. But if we look, there's only one that has try in it. The other two have trap. So try means 3, and look, it's the 1, 2, oh, it's the third one, right on. Okay, so try is the third one, the triquetrum. That's how I remember that. And then in the next row, we have trapezium and trapezoid. How do you remember which is which? Well, trapezium is closer to the thumb. And that's how I remember it. Trapezium is closer to the thumb. I don't know if it'll help you, hopefully. And there's also some acronyms, mnemonic devices you can try to remember. So what we're going to do is we're going to adapt this for our class. I adapt it every year. So instead of Sally, it is now Suki, right? Or Stefan, because we got 2 this year with S's in their name. So Suki and Stefan like to party, try to call him or her. Okay, so you see how the first letter, right? S, L, T, try is the third one. P, trapezium is closer to the thumb. Trapezoid, capitate, hamate. So there you go. That's how you're going to remember it. And you can make up your own. It's up to you. However, you do have to remember where it starts, right? So if we're using this acronym, we're starting proximal on the lateral or thumb side. And then we're starting in the proximal row on the lateral side, moving towards medial. And then we go to the distal row. So that's the split there. This is the distal row. This is the proximal row. Because some people, some evil instructors are going to ask you to, okay, can you name the distal row of carpals from medial to lateral? So you're going to have to go backwards. But if you remember it this way, you can always then just write it out and then work your way backwards. You know, because we're a little bit evil like that sometimes. Okay, just me. Anyways, moving on. Do you guys have any questions of that? So those are just like in our foot when we had like your cuneiforms, cuboid, navicular, right? Those were all weird names too. Same thing, just in our wrist. And then, just like in the foot, we had metatarsals. Now we have metacarpals. So these are the bones that are found in the palm of your hand. Okay? So again, when I was studying, first learning this, I thought this was my whole finger. And then this was the palm, this was my big thumb, and this was the palm of my hand here. Well, it wasn't to scale, that's for sure. So no, this is the palm of your hand in there. So the metacarpals are numbered 1 to 5, with 1 being at the thumb. and then 2, 3, 4, 5. So you know when we talk about in massage, we talk about the thenar eminence and the hypothenar eminence. So the thenar eminence is this part here, the drumstick of your thumb. And then the hypothenar eminence is the metacarpal of your pinky that lines up with the pinky. And just like in the foot, we had base, which meets up with the carpal bone, a shaft, and then the head. And the head meets up with a phalange. So hopefully you're feeling okay with these bony landmarks because it's very similar to the foot. Taking you way back. See how we're coming full circle? It's almost like someone planned this or something. Imagine that. Now we got the phalanges, right? Oh, thenar eminence and what? Oh, hypo. So thenar eminence and then hypothenar eminence. So I'll just go back a sec. Where is it? Right there. Thenar eminence is with the thumb. Hypothenar eminence is that bulky part of muscle by your pinky, on the pinky side of your hand. No problem. So the phalanges, just like the foot, right? The thumb is the equivalent of your big toe, and it only had 2 phalanges. Same thing with your thumb. The rest of your fingers have 3 phalanges, and they all have a base, a shaft, and a head. So you see the parallel, how it's, see your thumb only has 2, but your fingers each have 3. And then we have joints here at the wrist. So anytime 2 bones meet up, they form a joint, right? So we've got the radius meets up with the carpal bones, mainly the first 2 bones, which were the scaphoid and the lunate. You'll notice there's a gap between the ulna and the carpal bones, and that's because, as you're going to see in more slides, that there's a disc in there. So the motions we get at the wrist between the radius, so the radiocarpal joint, this is our wrist joint. When we say wrist, we're meaning radiocarpal joint, even though there are more joints here. Just like, remember with the elbow, what we mean is the humero-ulnar joint, but we just say elbow. So the motions at the wrist, we talked about earlier, flexion, extension, ulnar deviation, and radial deviation. So which motion do you have more? Ulnar deviation or radial deviation? Which one is greater? Which one do you have more range? So if I try to bring my thumb to my forearm, that's radial. I don't got much range, right? But ulnar, yeah, I got lots of range of motion going ulnar if I start from neutral. Yeah? And that has to do with, because look, you have that extra gapping in here. So it allows you to have more range of motion. Whereas when you try to go radially, you'll get more bone-on-bone contact, and that'll stop you, limit your range of motion. Then we have intercarpal joints. So anytime 2 of these carpal bones meet up, they form a joint. You don't have to know them all individually, and there's lots of ligaments there, but you do have to know that those joints do play a role in all the motions of the wrist. And same thing with the carpo-metacarpal joints, so that's here. Those play a role with the wrist motions as well. All right, here we go. Now we can see we're looking closer at the wrist joint, the radiocarpal joint. It's a condyloid synovial joint between the radius and the proximal row of carpal bones, but mostly just the scaphoid and the lunate. You'll notice there's a disc found between the ulna and the carpal bones. And we've got more ligaments here. Radial collateral and ulnar collateral ligaments. Then, of course, we've got a palmar radiocarpal ligament, so on the palm from the radius to the carpals. And we already talked about the motions, wrist flexion extension, and ulnar and radial deviation. Here now we're talking about the intercarpal joints. Specifically, so again, like I said, anytime two of these carpal bones meet up, they form a joint. But then there's a specific joint called the mid-carpal. So you see the red dotted line here? That is the mid-carpal joint. So it's between the two rows of the carpal bones. So they're all planar synovial gliding joints. Lots of ligaments in there, lots. And they assist the wrist motions, or the motions at the wrist. And finally, we have the carpo-metacarpal joints, so between the carpal bones and the metacarpals. So digits 2 to 5, so your fingers, there's not too much motion there between the carpal bones and the metacarpals. But when we get to the thumb, this is that unique saddle joint, okay? So the trapezium and metacarpal 1, which is in the thenar eminence, okay? So you know that meaty part at the base of your thumb? That is a specialized joint, a saddle joint. So you have way more motion available there. As you know, your thumb can move way more at that joint than your fingers can, right? And it's very similar to a ball and socket. It has the same characteristics, but it's a saddle joint. But it just means it can move in a lot of planes. Let us do a lot of things. Any questions with that? Do you guys know what I mean when I'm talking about that joint, or do you want me to show you? Crickets, you guys are sleeping. I knew it. You're drinking. Janice. You guys. All right. Now we have flexor retinaculum. So flexor retinaculum, we have it in the ankle, we have it in the wrist, and it prevents the flexor tendons from moving away from the wrist. So we got from the pisiform and the hook of the hamate, so on this side, traveling all the way over to the scaphoid and trapezium. And that forms the top or the cover of the tunnel. And then the bottom of the tunnel is your carpal bones. And through the tunnel goes the median nerve, which innervates your thumb, index finger, middle finger, and half of your ring finger. And we've got other muscles in there passing through that tunnel: flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus, and sometimes, depending on the textbook cadaver, flexor carpi radialis. That will not be a test question, but you should know that the muscles that flex the fingers and thumb travel through that tunnel. That's coming up next unit, and we're going to look at carpal tunnel again next unit. But this is just a little introduction to it. And then on the back, of course, we have an extensor retinaculum traveling from the radius to the styloid process of the ulnar, the triquetrum and the pisiform, so it wraps around a little bit to the front. And same function to stop the extensor muscles, the tendons, from pulling away from the wrist, just to keep things in place. Aha! Good question. So if the median nerve is compressed within the carpal tunnel, you're looking at these muscles. The tendons of these muscles might be inflamed. Oh, we're going to get to all that next unit. We're going to do it with the hand though. But that's just a little teaser, I guess. All right, so how are the actions? How's your understanding of the actions? Feeling okay with this? You have to let me know if you have questions. Okay, so these muscles have really long names, usually, but it actually helps us out because it tells us what they do and where they are, sort of. So I put the images on the next page because they were just too long and wasn't doing justice, but yeah, kind of like in the feet, exactly. So we're going to take a look and we're going to try, I'll try to give you some hints on how to remember this stuff. So first of all, what does the word carpi mean? Carpals, which mean wrist. So this muscle's flexor carpi. So what does it do? I flex the wrist. Yeah, exactly. So easy. Radialis. I'm a little bit closer to the radial side. So if we notice, look at the common thing here. These three muscles flex the wrist. Look where they all originate, for the most part, on the medial side of the medial epicondyle of the humerus. Remember when I had you flex and extend your wrist and feel where it bulges, right? So that it was on the medial side. It bulged when we flexed. And then if we take a look at our hand, well, the metacarpals, the base of metacarpals 2 and 3, that's the metacarpal of your index finger and middle finger. Those are closest to the radial side. Would you agree? Okay, so metacarpal 2 and 3. And then what's on the ulnar side? Look at that, the pisiform, the hamate, and that metacarpal 5 is on the ulnar side. So that you can use these pieces of information in their long names to help you figure out where they go. And then palmaris longus, well, it goes into the palm of the hand, if you have it. Lots of people are missing this muscle. So palmaris longus is unique in that it doesn't insert onto a bone, it inserts onto fascia, the thickening in the palm of your hand. They all do wrist flexion, and then look at this. Flexor carpi radialis does radial deviation. It had the word radialis in it. Ulnaris, what could it do? Ulnar deviation. So it's like the name just gave away all its information. So hopefully that helps you. But let's take a look here. So they all start on the medial side, medial epicondyle. Radialis went to the base of metacarpals 2 and 3. Ulnaris went to the pisiform, hook of the hamate, and 5. So can you see now with these diagrams how one is more on the radial side and one is more on the ulnar side? And then Palmaris longus goes right in the middle to attach to the palmar aponeurosis. How are you guys doing? Is this too much? Not yet. Okay, good. Good. Well, we're halfway through the muscles of this unit, so that should make you feel good. Oh, whoop. Okay, so now let's look at these. These are your wrist extensors. Extensor carpi radialis longus. So if we have a longus, we're going to have brevis. And then extensor carpi ulnaris. Good. All of these, look at this. From the lateral epicondyle of the humerus. Longus goes to 2, brevis goes to 3, and extensor carpi ulnaris goes to 5. Metacarpals, right? Base of metacarpal 2, 3, 5. They all do wrist extension. The 2 that have radialis in it do radial deviation, and ulnaris does ulnar deviation. So to help you guys remember about the difference between longus and brevis here, so brevis goes to base of metacarpal 3. How I remember that is if you draw a capital B and then you erase the line, what number are you left with? A 3. Do you see that? Yeah, that's how I remember that, because there was no way I could remember that otherwise. So I just would do silly things like that. So here, when you look at this image, these 3 images, we can see the olecranon here. So this means we're looking at the front or the back, anterior or posterior view. Yes, posterior view. Good. So now the lateral epicondyle is here because we're looking at the back, so it's closer to the radial side. And we've got ulnaris going to the base of metacarpal 5. Brevis went to the 3, and longus went to 2. There you go. And that's it for the muscles of this unit. There's just 6. And here we are, muscles of ulnar deviation. I left them blank because there are 2, and you should be able to fill them in. We already talked about them. It was the ones that had ulnaris in it. Radial deviation, the ones that had radialis in their name. And that's it for the muscles of this unit, you guys. Not a hard unit. Yes, flexor carpi ulnaris and extensor carpi ulnaris do ulnar deviation. If they have the word radialis in it, they do radial deviation. So their names are giveaways, right? Okay. Brachial plexus. So here we have the axillary nerve for deltoid teres minor, radial nerve. These are all the muscles we've learned. So generally for radial nerve, you're thinking, for the most part, the back of the arm and the extensors. The median nerve, your pronators, a flexor, and your ulnar nerve, a flexor. So again, I don't test too heavy on this, but you're going to want to start becoming familiar with these nerves and whatnot for next year. And same thing with blood supply, right? Brachial, radial, ulnar. This was in the elbow unit. It's going to be in the hand unit. Veins got the same names. Aha. So now we have tennis elbow and golfer's elbow. So even though they have the word elbow in it, it's actually due to motion at the wrist. That's why it's in this unit. And the muscles are the muscles that move the wrist. So even though it says elbow and the pain is at the elbow, it's actually due to a motion at the wrist, usually. So for example, tennis elbow is like if the motion is as if you were doing a backhand in tennis. Okay, so snapping your wrist into extension. So you're overusing the wrist extensors and those muscles get strained. So you get pain and inflammation on where do those muscles originate? The extensors originate on the lateral epicondyle of the humerus. Golfer's elbow is now doing a forward golf swing, so that would be overuse of the wrist flexors. So you get, again, pain and inflammation, but this time on the medial epicondyle of the humerus. But look at this. Look at the treatment. They're the same, just in a different location, right? You would ice massage the inside or the outside of the elbow, right? They may need surgery. They may need to go to physio. They may need a brace. First of all, number one, rest. Stop doing the activity that's aggravating it, which is hard to do if you're, if it's your job or you're an athlete or what have you, right? But there's your tennis elbow and golfer's elbow. Any questions with that? Tennis is ice lateral, golfers is ice medial. No problem. Can I go back to the nerve side? Yep. Okay, so what we're going to do is take, we are not done for the evening. Nice try. I'm actually going to, because I was just looking at the schedule going forward, and I was either going to add a class, which, let's be honest, who wants to do that? Well, I do. I don't know if you guys want to. But instead, if I use the time tonight and do a run through of the hand, like here's the thing with the hand. We already did the bones. Do you know what I mean? Like we just have to do joints and muscles for the hand. And then you guys can listen to the recording. It's all on one recording. And then next class, we can start review already. I think that would be better. And then the seminar, we have lots of time for the presentations and for more review. So I think that's what we should do. Yeah, so we're going to take a little break, like at least 5-minute break. and then we'll come back, well, I'll meet back here and we'll do the hand. Okay? So, take 5-7 minutes. That should be good for everyone. And then we'll go from there. Take very long. All right. So the hand, this is the last unit besides the pelvis, which acts like a review, but also covers the abdominal muscles. But really, like, we're going to be done the body right away. So it's pretty exciting. Same old outline. So here we have finger motions. So we've got, you can label these if you want with the marker. Which one is abduction, adduction, and which fingers are flexed and which are extended in these pictures here. So hard to write on this stuff. Okay. AB, AD, flexed, extended. Good. Looking good. Check marks for everybody. Very good. Okay. So here's what I have. But I think, let me see. AB, A deduction. Do not cross that out. Do not write that there. So your ABA deduction happens at your metacarpophalangeal joints. Good. Your flexion and extension happen at the interphalangeal joints, but also at the metacarpal. So also write this one, metacarpophalangeal down there. Both. Leave it there with ABA deduction, but write it again for flexion extension because you do get some flexion extension happening right here. But that's also where your ABA deduction comes from. Good. All right. This thumb business. Okay, good. This slide's correct. This thumb business drives me nuts because to me, like if we're talking, well, anyways, yeah, if we're talking anatomical position, flexion, extension occur in the sagittal plane. So to me, that would be here and here, but it's not. That's ABA deduction, which is frustrating. Flexion extension is across and out, which to me means ABA deduction. So I don't ask about this on tests because it's just silly. And if you had to do APR on it, you would pick whatever action and just do it on both thumbs and then do the other, So whatever. It's so confusing. I don't know why they just had to make this exception. It's silly. And then opposition is just when your thumb crosses over to interact with your pinky. But anyway, yeah, silly, silly. So here's what I'm saying. Don't really worry about it. Okay, as for the bones, we did this whole section with the wrist. So we're not doing it again. And we did the wrist joint, we did the metacarpal joint. This is the one we have to do. We did the carpometacarpal joint, but now we got to do the MCP, metacarpophalangeal. So those are these right here. Between the metacarpals and the phalanges. They're condyloid joints, synovial, between the heads of the metacarpals and the bases of the proximal phalange. So here we get flexion, extension, abduction, and adduction of the fingers and thumb at these joints here. And then the only other joints we have are interphalangeal joints, so between the phalanges. They are hinge synovial joints. They have collateral ligaments, and we get the motions of flexion and extension of the fingers and thumb. So you got your pips and your dips, right? Distal interphalangeal is your DIP, dip, and proximal interphalangeal is your PIP, PIP. And you can see them in the picture here. So it's where the base and the head of phalanges meet. And we already talked about the extensor retinaculum. So now we'll talk about the extensor expansion ligament. So it's the bands in between and at the back of the hand. There's 3 strips of tendons. So they're the extensor expansion ligament, also called the dorsal hood, which is on the back of the hand. And on the front, okay, we already talked about the flexor retinaculum, which is sometimes also called the transverse carpal ligament, and that's what had to do with the carpal tunnel, okay? And that's the one right here, flexor retinaculum. If we look proximal to that, we see a palmar carpal ligament. And it's superficial and proximal to the flexor retinaculum. And in between there, we've got the ulnar nerve and artery. Okay, so remember the median nerve went through the tunnel under the flexor retinaculum, but the ulnar nerve and artery travel between the palmar carpal ligament and the flexor retinaculum. This is important because, as you'll see with carpal tunnel syndrome, if someone has numbness and tingling in their thumb, index finger, and middle finger, that's more likely carpal tunnel. Whereas if they're experiencing it in their pinky and ring finger, and one half of their ring finger, that has to do more with the ulnar nerve, and that has nothing to do with the carpal tunnel. So that's, you guys are going to be little detectives figuring all that out. Oops, sorry. So just like in the foot, our foot had arches, right? Oh, so what about just the middle finger? Oh, there's just abnormal sensation in the middle finger and no other finger, or the third finger? Ah, good, stay in school. What is that going to mean? So just like the foot has arches, the hand has arches. And the arches help allow your fingers and thumb to interact. So it allows us to grasp objects, increases the amount, how about we spell, there we go, of surface contact that our hand can have on an object, which helps us be more stable with that object, manipulate that object, increase the amount of information that comes to our brain. So like when you do massage and you conform your hands to the tissue, those are the arches of your hand letting you do that, right? You can wrap your hand right around that tissue. So now we have the muscles. We're not going to do the actions again. We'll just do the muscles. So the muscles of finger extension. Look what word they have in common in all their names. Extensor digitorum. Extensor digiti minimi. It's like mini-me, okay? Extensor indici is the first, your index finger. So generally, because these are extensors, they're on, look at that, the lateral epicondyle of the humerus, except for extensor indici. So you just have to remember that one's a little bit different. So the lateral epicondyle is here. And then they're going to go to the base of the distal and middle phalange of digits 2 to 5. So this one goes to like that, like so. And then your pinky finger gets an extra muscle, and it goes just to the distal phalange of digit 5. So it starts same spot, but it goes just there. Again, I'll put it in black, something. There, I guess an extra one. And then we have extensor indici. It's on the distal posterior ulna and on the interosseous membrane. And it goes to the base of the distal phalange of the second digit, which is your index finger. So it crosses over. So their job is to extend the digits. So your index finger and your pinky finger get an extra little helper muscle there. And the thumb we're going to talk about separately because it gets its own muscles. And then the muscles that do finger flexion. We've got flexor digitorum superficialis and flexor digitorum profundus. So superficial and deep. If you're profound, you're a deep thinker, right? So it means deep. These muscles are the ones that have to do with carpal tunnel syndrome. Okay, they travel in the tunnel. So we've got flexor digitorum superficialis. Let me get a different color here. Starts on the medial epicondyle of the humerus. It's also on the coronoid of the ulna and a bit on the radius. Okay, so it's got a big origin. And then it goes down the wrist, and 4 tendons will cross in the tunnel to go to each digit. And it splits the tendon. So it splits here. The tendon splits into 4 through the carpal tunnel, and then it splits again and goes to each side of the middle phalange. Okay, so take a look at this muscle when you get a chance in your textbooks and stuff. Because then we have flexor digitorum profundus. So it's on the proximal anterior medial surface of the ulna. Okay, good. It will split into 4 tendons as well through that tunnel. See how full that tunnel is going to get? And it goes to the base of the distal phalange. So it just splits once. It doesn't split again. But it goes all the way, it goes farther because it's deeper. I don't know if that's why, but that's just what I remember. So it goes to the base of the distal phalange. So again, flex the fingers. Of course, it can help with wrist extension because of where they cross. they cross the wrist joint. So far we have a total of 8 tendons going through there, 4 and 4, right? And we're not quite done yet. So thumb extension. So in the foot, the big toe was hallucis, correct? Now in the hand, the thumb is pollicis. So extensor pollicis longus, extensor pollicis brevis, and abductor pollicis longus, which does both extension and abduction of the thumb. So we'll do extensor pollicis longus, middle posterior ulna, and the interosseous membrane. Goes to the base of the distal phalange of the thumb, does thumb extension. So that was pollicis longus. Brevis, posterior distal radius. So look at that. Which is closer to the thumb, the ulna or the radius? Yeah, the radius. So that's why it's brevis, right? It's closer to. The ulna was farther, that's where longus was. So brevis starts on the radius on the interosseous membrane and goes to the base of the proximal phalange. So see how it's shorter? And then abductor pollicis goes to both. Posterior radius, ulna, interosseous membrane, so it's all in here too. But it goes to the base of the first metacarpal down there. So it does abduction and extension of the thumb. And then we only have one muscle in this unit that does thumb flexion, and this tendon passes in the carpal tunnel as well and can contribute to carpal tunnel syndrome. So we're on the anterior side now. So anterior radius and interosseous membrane to the base of the distal phalange of the first thumb, does thumb flexion. Of course, there's way more muscles that move the fingers, but they're all intrinsic muscles. They start and end in the hand, so we don't cover them. You may go learn them when you have time, but you don't have to right now. So now we have a total of 9, at least 9 tendons going in the carpal tunnel. Sometimes 10 if flexor radialis brevis is in there as well. Depends on the textbook. I know, when you have time. I was just seeing if anyone's listening. Ha! What is time? Okay. So here's that chart again. The ones in bold are your new muscles of this unit. Okay, so you see how the median serves a lot of the flexors, and of course the ulna too, ulnar nerve. And look at this. The common thing with radial is extensor. Hey, look at all that. So if you have to guess, right? And we already did the nerves. So now we just have carpal tunnel. So the issue with carpal tunnel generally is overuse of your fingers and thumb. So flexion and extension of the fingers and thumb. So generally when we massage, we're not doing flexion and extension of our fingers and thumb. So if you keep your wrist in neutral when you massage, you will not get carpal tunnel. But if you start deviating it or flexing, that can compress the tunnel. So you're more likely to get carpal tunnel if you're doing lots of typing, piano playing, right? Flexion, those kinds of motions, gripping, lots of gripping and releasing motions. Not so much massage, though massage therapists get it. It's not from the finger motion, it's from not keeping your wrist in neutral. So that's why we are often on you guys to keep your wrist in neutral. So you're, of course, so remember, okay, let me show you this picture here. This one. We're kind of looking at a side view, or I don't know, down the hand. So in here, we've got a bunch of tendons, and we got the nerve, and we have just a limited space. Okay, so the carpal bones are on the bottom, the flexor retinaculum's on the top. Those tendons slide in and out of a sheath, and if they're overused, those sheath, they rub against each other, create inflammation. That takes up more of that space. Eventually, we run out of space and that nerve gets compressed. And it gives weird sensation in the thumb, finger, middle finger, but only half of the index of the ring finger. That means your median nerve is compressed. And it could be carpal tunnel. Now it could be other things. That's where you guys have to do a bunch of testing. You're going to learn how to test for it, how to check for it, all this stuff. Okay. So of course you can do massage to help. Sometimes the person needs surgery. Sometimes it's not coming from the carpal tunnel. It's just mimicking carpal tunnel syndrome, and it's actually coming from somewhere else. And you're going to learn how to figure that out. So that's kind of fun. And so here's the picture of the median nerve and the fingers it impacts. So if someone's saying it's the pinky, then it's definitely not carpal tunnel. A nerve could be impinged, but not in the carpal tunnel. That's all. So a little detective work you can do when you know so much about the body, right? So hopefully, well, hopefully you guys are doing all right. There's not that many muscles in this unit either, just the muscles that move the fingers, right? There were only 6 in the wrist unit, which is good. And then we just have the abdominals and pelvis left, which is amazing.